Okay, so we're going to move on to part B of the endocrine system, but just want to kind of go through the highlights of the first PowerPoint. The first PowerPoint, Endocrine 1, basically just went through the function of the endocrine system. What does it do? Well, it creates homeostasis. It works in conjunction with the nervous system. They work together to maintain normals in the body. But the endocrine system uses hormones. The nervous system uses neurotransmitters. So unlike the nervous system, the endocrine system is slow communication. It's got some longer responses. Remember the nervous system is a zap. Zap. Here's my neurotransmitter. Do this. The endocrine system is slower. Those hormones getting to the blood. They can act over long distances. So, that neuron in the nervous system, that zap, goes directly to a target. Boom, right there. Extremely short distance. But some of these hormones that are from the endocrine system are traveling pretty long distances, like from the brain all the way down to the ovaries or the testicles, for examples. Let's see. The targets for the endocrine system are varied. It can be very specific targets, or it can be numerous targets. It just depends on what the hormone is and what cells have the receptors for that hormone. Another thing was the classes of hormones, the way that they're made. So there was amino acid hormones, or sometimes you'll see it written as peptide hormones. Remember, that's the same thing. It's all breakdowns from a protein. And then the other kind is a steroidal, so like from a cholesterol base is how they look chemically. And why is that important? Well, it depends that how they're made determines how they affect the cell. So an amino acid can't get into the cell easily. So what it's going to do is it's going to set up house on a receptor of the target cell, and then we're going to have a secondary effect. We're going to have what's called a second messenger gets activated. That second messenger lives inside the cell, and it's going to be converted into something else. So a series of steps, but when it finally gets to its second messenger state, it's going to alert all the enzymes inside the cell to get busy and get started to tell the cell, hey, this is what this hormone wants you to do. Cyclic AMP is probably the most common one, but there's others that you don't need to memorize, like PIP2 and stuff like that. Your book lists several, don't worry about that. But you do need to understand that for the amino acids, that hormone, the amino acid hormone, doesn't actually get into the cell. Now the steroidal hormones, since they're from a cholesterol base, that makes them a lipid, and they can get right past those phospholipid tails and go and affect directly the cell. It actually gets into the DNA. And, any of these hormones they basically tell that cell what to do. It's going to alter that cell's activity. So maybe it changes the permeability of a cell, or maybe it causes a cell to secrete whatever it's supposed to secrete, or maybe it causes mitosis. There's lots of things. What's the cell's job? Whatever the cell's job is, the hormone tells it, get busy, do this job. One other thing that I'm thinking of, the 3 ways that the endocrine system gets, or the endocrine gland gets stimulated. So by the blood, that's called humoral or humoral, depending on who taught you. I learned humoral response. So some sort of substance passes in the blood, and that's how the endocrine system gets stimulated. The second one is neural. So maybe you actually have a neuron or a neural response causing the gland to release its hormone. And then finally, the most common one is hormonal. So here comes this hormone, and it goes and tells this gland, hey, I need you to release your hormone. That's the most common. So the 3 kinds of way endocrine gland can get stimulated: humoral, neural, and hormonal. And then finally, let's see, we talked about how the hormone can influence the number of receptors available. So upregulation, downregulation. So review that. And then we went into the different, we started with the brain. We started with the hypothalamus and the pituitary gland. So the different hormones coming from the brain. The hypothalamus has releasing and inhibiting hormones. So corticotropin releasing hormone, for example, there's several of them, but they're going to go and tell the anterior pituitary what to do. So we'll get into that in a second. The other kind of hormones that the hypothalamus releases, besides those releasing and inhibiting hormones that tell the anterior pituitary what to do, the other kind is antidiuretic hormone and oxytocin. It doesn't tell the pituitary what to do. Those guys have a job, but they're going to get stored in the ends of the axons that came from the hypothalamus. They're going to get stored in the posterior pituitary because the pituitary gland has a glandular part, the anterior pituitary. So if it's glandular, it can make hormones. And then there's the posterior pituitary part. It's not glandular. It's just a whole bunch of axons passing through it, so it's tracts, and it's storing ADH and oxytocin. So the hypothalamus is connected to the pituitary physically by an infundibulum. It's a piece of tissue. It's a little stalk. And it's connected vascularly, so the vessels that are the blood system going from the hypothalamus to the pituitary gland is the hypophyseal portal system. Portal system just means there's a capillary bed on two ends. And then we went into the hormones from the anterior pituitary. So growth hormone, thyroid stimulating hormone, adrenocorticotropic hormone, and the gonadotropins, so FSH and LH, and prolactin. But now we're going to move a little bit past the brain. We're going to get into the thyroid here. This is a huge one. The thyroid hormone affects the whole body. It's a butterfly-shaped gland in the anterior neck of the trachea. Maybe you remember from MP1, the baby, you had to learn to tell the difference between the thyroid gland and the thymus. The thymus is in the chest. So, and why did we use the baby model? Well, because the thymus is not big in adults. It starts to go away. All right, so the thyroid looks like a butterfly. There is a connection between both sides of those wings called an isthmus. And in lab, you're going to have to learn, use these slides to help you with lab to identify histologically what the thyroid looks like. So what does the thyroid look like under the microscope, right? Histology is the study of tissues. So what does that tissue look like under the microscope? It has all these cool circles, and the circles are called follicles. And inside that follicle is where you're going to see the creation of thyroid hormone. Colloid. Colloid is all the substance, the fluid that's filling up those circles, those little spheres that the thyroid hormone is floating around in. And then para, remember para is beside. So the cells that are besides all the spheres, so outside of the sphere, in between the spheres, those are going to be parafollicular cells, and that produces a different hormone called calcitonin. So the thyroid gland is responsible for thyroid hormone and calcitonin. If you don't remember from the skeletal system, in AMP1, calcitonin helps control calcium. So here's a detailed picture so you can see exactly where that guy lives. And here is a histological slide of the thyroid. So let me find that little pointer. Here we go. This is a follicle. This is a follicle. This is a follicle. So all the fluid that's floating in these little follicles, because it's a gland, so it's filled with fluid. The fluid's called colloid. And we're going to have a whole bunch of things called thyroglobulin in there. So there's a protein in here, thyroglobulin, that the follicular cells are making and putting into this colloid. And then it has to get converted into thyroid hormone. Let's see, let me do the, okay, so here's a follicle, here's a follicle, here's a follicle. Parafollicular, so next to the follicles, there's these other cells you see with those little nuclei. These are parafollicular cells, and those are the guys that are going to be in charge of making calcitonin. Close-up picture. Here we go. Beautiful. So like I already said, the thyroid hormone pretty much affects every cell in the body. Every cell needs to do some sort of catabolic activity and some sort of anabolic activity. And remember, the definition of metabolism is the sum of anabolism and catabolism. That's first week of AMP1. Okay, so thyroid hormone actually comes in two forms. It depends on how many iodine molecules bind to it, or iodine atoms. T3 is the active form, the form that actually, the hormone that actually changes, affects its target cell. But we have a whole lot of T4. So a lot of the T4 is going to get converted once it gets to the tissue it's supposed to affect, to T3. I'm not going to ask you to draw this, but yeah, that'll be a different page, I guess. Okay, so we'll go through that in a minute, the difference between T3 and T4, but we'll go through the effects here. So the goal is to increase metabolic rate and heat production, critical for your bones and nervous system to develop. So I mentioned in the first PowerPoint that if now they test babies for thyroid hormone, make sure their thyroid's working, because if they don't, that baby, and it's not caught, that baby is going to be physically and mentally affected. Thyroid hormone helps maintain our blood pressure. Here's that picture. Okay, and there's probably a series here. Okay, so this right here, what we have a picture of is, this is the follicle cell, okay? So somewhere there's a nucleus that's not drawn, but here's the rough ER. You remember we've got to do protein synthesis, right? So here's the rough ER. It's making protein, and it's going to go through the Golgi apparatus and get all packaged up right here. And then it's going to exocytose out. So what is this? This is the thyroglobulin. Because I said the follicular cells make a protein called thyroglobulin, and then it's going to float around inside that follicle in the colloid. So here you see in a blown up area right here. So these little lines are the thyroglobulin, and they're floating around in the colloid. Okay. Next. Because you have iodine in your diet, it's going to get broken down to iodide. And this is why they add add iodine to your table salt, because you must have iodine in order to make your thyroid hormone. Very, very, very important. I appreciate sea salt very much, but if you're a really healthy eater and you're thinking you're doing good by not having table salt with iodine added, then I hope you eat a lot of shellfish, because that's the next place that we get iodine from. Talk about that in a minute. Okay, so we also have iodine coming in. This is a blood capillary that's passing by the follicular cell. The iodine comes in, just passes on through, goes right out into the colloid, and is going to follow or find a thyroglobulin molecule, and it's going to bind up like this. So you have some of these molecules are going to have just one attachment of iodine to it. Some of them are going to have two. And then what's going to happen is sometimes the ones with two pair up with another two. So that's 4. And then sometimes you're going to have ones with 2 just bind up with ones that just have 1 iodine attached to it. So therefore, that's how you get T3 and T4. But again, you make a lot more T4. In a nutshell, all of that's going to end up back down into the bloodstream, and they're going to go find their target. And this is what I just said. Mostly you have T4. T3 is also secreted. T3 is the most active form of thyroid hormone. So whenever the T4 hits its target, finds its target, that cell is going to convert it to T3. And we're not going to get into that much detail about, well, we're not going to get into any detail about how exactly the target cell breaks that down into T3. It just has an enzyme that's going to take off an iodine, that's all. Not a test question. All right. And then it's most of our hormones are negative feedback. That was the last slide. Okay, so here's how it works. We've got the hypothalamus. Remember, the hypothalamus has releasing hormones and inhibiting hormones. So this is thyroid releasing hormone. Goes to the anterior pituitary. The anterior pituitary releases thyroid stimulating hormone, which goes to the thyroid gland. So the thyroid gland releases T3 and T4. TH is thyroid hormone. And then, of course, once you get enough, then you have negative feedback. And this would be an example of tropic hormones. A tropic hormone is the hormone that's released because another hormone told it to be released. So this is a homeostatic imbalance, a disease. What happens if you don't secrete enough thyroid? Well, in adults, you can actually kind of tell that they're really slow. So if thyroid is important for your blood pressure regulation, if thyroid is important for your metabolism, then what you're going to see is problems with blood pressure. You're going to see problems with being cold. You're going to see sluggishness. So if it's important for your mental health. I personally know someone that I worked with her, and she was really sweet, and she eventually could get the job done. But oh my gosh, she was like a sloth. And she always kept forgetting to take her thyroid medicine. And it's like, honey, that's important for more than just, getting through your day. It's important for your heart, and it's important for your blood pressure and everything. So she was young. Hopefully she's figured it out by now. Sometimes, like I mentioned earlier, it might not be because you're not making thyroglobulin. Might be because that's misspelled. It's not supposed to have an E on it. It might be because you're not taking in enough iodine. Well, your brain's still working. Your brain is still saying, okay, I don't have enough thyroid hormone floating around. So your body, your brain is going to keep putting out, your pituitary gland is going to keep putting out TSH. And your hypothalamus is going to keep putting out thyroid releasing hormone. Okay. So your thyroid is going to keep producing thyroglobulin. And what will end up happening is your thyroid gland gets bigger and bigger and bigger because it's doing its best to do what it can do to make thyroid hormone. But if you're not taking iodine into your diet, you can't make thyroid hormone. You must have iodine in your diet. So what will end up happening is that all those little spheres full of colloid just gets bigger and bigger and bigger and bigger, and that thyroid enlarges. I have a picture of that in just a minute, but this is a picture of a person that has hypothyroidism and has myxedema. I don't think I went into enough detail on that on the last slide, but it causes fluid to actually start building up under the skin. And on the left-hand side, this is before she gets treated. So treatment for our hypothyroidism is just you take a pill of thyroxine. You just put it in your mouth since your body's not making it for whatever reason, usually not making enough thyroglobulin. Well, then you just take the hormone itself. And you can see all the swelling has left her face. The swelling is called myxedema. The swelling in her face, the puffiness in her face is called myxedema. This is a person with that swollen thyroid because she doesn't have enough iodine in her diet, or at least at some point she didn't. This swelling right here is called goiter. So her brain kept putting out TSH and kept putting out thyroid releasing hormone, TRH, but her thyroid just couldn't make any iodine. So again, those follicular cells kept making thyroglobulin, but so what? What good does that get to do? Nothing, because the thyroglobulin can't leave because it didn't get bound to iodine. Now, she can start taking iodine, or, whether it's supplemented or she starts eating more shellfish, because that's a common place to get it. But that swelling will never go down. That goiter is forever. Before we found out how important the iodine was in our diet, in the United States anyway, coastal areas where there's lots of availability of fresh seafood, coastal areas didn't see goiter. But the middle states, they didn't have access to shellfish. And of course, back in 30s, 40s, it was expensive to ship those kinds of foods. They have to stay cold or else they go bad. So we figured out that, okay, well, we need to put some iodine in the diet, and goiter essentially has gone away in the United States. So thyroid hormone is critical for normal growth and brain development in early childhood. Fill in the blank. Think of it for a second from your lab book. Congenital hypothyroidism. Congenital means I was born with a non-functioning thyroid. What is that called? Think about it. Cretinism. So we don't see this hardly ever anymore, or at least we'll see it, but it's treated because babies get checked for thyroid hormone production the day they're born. There can be symptoms. Maybe the baby is weak, but they can be asymptomatic. This is from the lab manual. Physically and mentally underdeveloped, they usually die by the time they're 40. This incidentally could be a picture that would show up in your lab test. So this person has cretinism. So what if we make too much? This is another imbalance. So the most common kind of hypersecretion of thyroid hormone is called Graves' disease. So an autoimmune disease just means that the immune system is confused, and the body starts to make these abnormal antibodies, and these antibodies act like thyroid stimulating hormone, and they sneak in, bind to the follicular cells, and cause stimulation of thyroid hormone release. So it shouldn't. It's an abnormal thing that this guy is acting like thyroid stimulating hormone. I need you to make some more thyroid hormone. So if thyroid's job is to regulate blood pressure and to regulate metabolism and has an effect on the nervous system, look at these symptoms. Instead of being slow and sluggish because you don't, with the hypo, too low thyroid disease, now you have almost like anxiety, extremely nervous. You're skinny, elevated metabolic rate. You're burning everything that you eat. As opposed to a hypothyroid person, they might be retaining some fluid under their skin and also gaining weight despite a poor appetite. This actually can even, hyperthyroidism can even affect the heart, start to throw arrhythmias. These people are very hungry because their metabolism is so high, but they keep losing weight. So in a way, it almost mimics, if you know anybody with diabetes, it almost mimics uncontrolled diabetes because they are eating, but losing weight. This is why we have the importance of lab work. You know, you can't just guess what's wrong with somebody or something. So in the dog and cat world, dogs get hypothyroidism. It is rare for them to get hyper. Cats get hyperthyroidism. It's rare for them to get hypothyroidism. So if you can imagine a cat that already doesn't want to go to the vet and it walks in with hyperthyroidism and it's anxious and nervous, heart rate is through the roof, throwing arrhythmias, you think that's a good patient? It's not. Okay. But that's okay. I love kitties. Another symptom of hyperthyroidism in people is the eyeballs actually start to kind of bulge. So that's called exophthalmos. That's a great lecture test question. So these eyes are bulging because there's some fluid behind the eye, and actually scar tissue will develop. So even if you treat the person for Graves' disease, their eyes will probably stay that way, probably. So you can do radiation therapy to help with the thyroid cells. There's some medicine called methimazole that they can take. You can take the thyroid out, but in a minute I'm going to show you why that's a problem. That's exophthalmos. Okay. So in lab, we talked about the parathyroid hormones, and where were they? They were on the back side of the thyroid. The parathyroid glands are on the back side of the thyroid. 4 to 6 of them, maybe more. Everybody's a little different. And then there's those parafollicular cells that release calcitonin. Those two things are antagonistic to each other. So parathyroid hormone, it will be released if your calcium in your blood gets too low. Calcitonin might get released if your calcium gets too high. Parathyroid hormone actually is the huge player in calcium maintenance, but there are some things that cause calcium or calcitonin to be released. Sometimes we have found, and so that's why calcitonin is, we don't really see it causing disease very often, but because parathyroid hormone is the guy that's really in charge of calcium. But recently they've started using calcitonin as a treatment for osteoporosis, which is a disease where your body is getting little holes in it. It's definitely genetically linked. So here's why you can't just go and remove that thyroid gland without a worry. If you remove the whole thyroid gland, those parathyroid glands are very deeply embedded into the posterior surface of that thyroid gland. If you take out the thyroid gland, you're taking out the parathyroid glands. And again, the parathyroid hormone is the most important hormone for calcium homeostasis. You need calcium to contract your muscles. You need calcium to make your nervous system go. You need calcium to clot your blood. So you can see how that could just be causing a nightmare, a cascade of problems. So this is showing the posterior surface of what they look like. You do not need to know what the parathyroid gland looks like via histology. So I'll repeat that. You have to know the thyroid histology. You do not need to know the parathyroid histology. So exactly how does that parathyroid work? Well, I mentioned it before, at least in the lab video. We're going to get those osteoclasts to start breaking down bone, to release calcium out of the bone and get it into the blood. So parathyroid hormones released whenever our calcium gets too low. Also, the parathyroid hormone changes at the kidney tubule level, changes the way the kidneys handle calcium. So if your calcium is too low in your blood, instead of urinating out that calcium, you're going to reabsorb it, and it's going to leave the kidney tubules and be pushed back into the blood. Calcium and phosphorus are kind of opposite, so another thing that's going to do is make phosphorus leave the urine more so that we don't, to help minimize our calcium loss. Another thing that it does is it helps activate vitamin D. So if you remember, starting at the skin, we make a precursor to vitamin D3, cholecalciferol. It's going to get converted in the liver, and then it's going to get converted in the kidneys to a usable form of vitamin D3. And so the parathyroid hormone actually helps promote the activation of the vitamin D. Hyperparathyroidism, not common. It's sneaky. It's on the backside of the thyroid gland up against the trachea and the tissues there. So can you feel a parathyroid tumor on palpation? No. But if you can imagine, if you have a tumor that's putting out so much parathyroid, then the osteoclasts are going crazy, shaving that calcium out of that bone. Too much so. And it's also telling the kidneys, don't urinate that calcium out. So now we have amazingly high levels of calcium floating around in the bloodstream. And one thing, it's left the bones, right? So your bones are weak. Another thing, which can be a telltale sign for a case, is you x-ray that being, and all the soft tissue has white dots in it because mineral shows up as white on an x-ray. And so you have white dots in your liver, you have white dots in your kidneys, you have white dots in your spleen, white dots in the muscle on these x-rays. So that's mineralization of the soft tissue. Soft tissue is anything not bone, right? Brain, gallbladder, it's crazy. It can be pretty telltale where you say, okay, we need to look for hyperparathyroidism, but it's rare. Okay, the adrenal glands are those little adrenal, so on top of renal is kidney. They have two parts. The outer part is the cortex, the inner part is the medulla. We're going to see that again in the kidney later. Maybe you talked about it in A&P1 with the hair. The hair has a cortex and a medulla. Bone, that outer layer of bone on that long bone is cortical bone, and the inner part is the medullary cavity. So cortex is outside, medulla is on the inside. Okay, well, that adrenal cortex gets broken down into 3 layers as well, because there's 3 different kinds of hormones released from the adrenal cortex. So there's a superficial level, a middle level, and a deep level of that cortex. The adrenal medulla is nervous tissue. So at the very end of A&P1, we talked about how for the autonomic nervous system, it's a 2-neuron pathway, but sometimes the neuron of the second neuron will be the adrenal medulla, if you remember that. It's going to release norepinephrine and epinephrine. Here's the histology of the adrenal gland. You do not need to know histology of the adrenal gland. But here's those 3 zones that I was talking about. So a superficial zone, a middle zone, and a deep zone. And then this part right here is adrenal medulla, where we're going to have epinephrine and norepinephrine released. Okay, so here's the hormones secreted. That superficial layer is going to release a hormone called aldosterone, which we're going to see later helps control water, because it actually is very important for sodium balance. Water follows sodium. Sodium follows water, sorry. And so this guy, because he's in charge of salt, he also regulates water indirectly. And then this layer, there's a fine detail between cortisol and androgens. Androgens are masculine type hormones. Such as like testosterone-like hormones. Cortisol is the biggie. Cortisol is the one that you think of as your stress hormone. So on this, you see the adrenal cortex is, he releases lots of stuff, not just cortisol, not just your stress hormone. And this is going to play a part in how you take medicine, specifically any sort of steroid pack that you might get put on. Maybe you get poison ivy or something like that. You're going to take it in the morning. Get to that in a little bit. The names of these different kinds of corticosteroids are listed right here. So mineralocorticoids, the biggie is aldosterone. Minerals, sodium. Aldosterone is biggest control is sodium. It's a mineral. So mineralocorticoids. Glucocorticoids is that cortisol level. So cortisol, they cause sugar to be released into the bloodstream. Very anti-insulin effect. So glucocorticoids is the name for it because it has a huge play in glucose. The androgens, the male sex hormone that I just mentioned, are similar to testosterone. Those are going to be called gonadocorticoids. So those are the different types of corticosteroids. Okay, mineralocorticoids. So very important for especially sodium And remember from AMP1, if we're messing with sodium, we're messing with potassium, the sodium-potassium pump. And you know this already. If you get too high of sodium, it affects the extracellular fluid, right? People say, oh, I'm retaining water, I'm puffy, right? Well, your cells aren't getting fatter. It's the tissue around your cells is maintaining up, getting extra water. Water and sodium go together. Sodium and potassium are opposites. It is a very potent mineralocorticoid. It is very important to maintain your sodium-potassium balance, right? I mean, that's how we reset a lot of our cells, especially neurons, right? That sodium-potassium pump to get back to resting membrane potential. That's AMP1. So what does it do? Aldosterone works at the kidney level. It's going to work on the kidney tubules, and we'll see in the see it again in the kidney section of this class. But it causes the kidneys to reabsorb sodium. If we are reabsorbing sodium, then we are eliminating potassium. If you retain sodium, that makes your blood pressure go up. Okay, because you're holding on to more water. Water follows sodium. There's going to be times that you need your aldosterone to be higher to increase your blood pressure. Hopefully not very often. What do I mean by that? If we get a decreased blood pressure for some reason, that's when we're going to need aldosterone to increase the salt, to increase the water, to increase our blood pressure. How does it do that? We're going to touch on this in the kidneys again, but I want to go ahead. I think repetition is key to learning, so I'm going to go ahead and leave this slide in here. When we have a decrease in blood pressure, let's say you're hit by a car, whatever, car accident, and you're bleeding out, your blood pressure starts dropping through the floor because you're spilling all of your blood out. Well, that tells the kidneys to release a hormone called renin. Renin's job is to convert angiotensinogen to angiotensin 2, and that's going to cause aldosterone release. If that sounds complicated, it should. It's very complicated. But in a nutshell, for this class, for this unit right here, you need to understand that aldosterone's job is to increase sodium in the blood, and the end effect is to increase your blood pressure if you're in a crisis. And of course, if you're increasing your sodium concentration, you're decreasing your potassium concentration. If you start to get too much potassium, then we're also going to release aldosterone so that we can increase the sodium so we can decrease the potassium. You must have a balance. And if you're new to me, if I have it in small, it's interesting, but it's not huge test material. I would like you to know that I'd like you to see this ANP right here. Atrial natriuretic peptide is going to show up again in the heart, because if you're pounding on your atria due to high blood pressure, it's going to release, it's going to cause aldosterone to not be secreted because we need to decrease our pressure. So in a nutshell, it's going to end up decreasing sodium. So if we have a tumor specifically in that most superficial area that's causing an excess of aldosterone to be put out, that's going to cause high blood pressure, because you're going to end up with high salt. That's a big deal. Not that common. Okay, glucocorticoids, so mostly in the center of that adrenal gland. Your adrenal gland puts out glucocorticoids, so cortisol, at its highest level in the morning, and that's normal. That's what it's supposed to do. Okay? So that's very important. The glucocorticoids are released normally highest in the morning, getting our metabolism going, help us resist stressors, right? So you already have that normal stress hormone release, and negative feedback we don't want to release anymore. Also, like I mentioned earlier, it's called glucocorticoids for a reason. It helps maintain a normal blood glucose level at normal levels. The biggest glucocorticoid is cortisol. There's also cortisone and corticosteroid, but the biggest one that we'll talk about is cortisol. So you've actually already seen this or heard this from the previous PowerPoint. Your hypothalamus is going to release CRH, and it's going to tell your pituitary gland to release ACTH, and then your adrenal cortex is going to release cortisol. When it gets high enough, then it's a negative feedback. So starts off high in the day, decreases as the day goes on, unless you're fixing to take an anatomy and physiology exam. And so that would be an acute stress. And I say acute because it's only over a period of, 3 days, maybe. And that interrupts your normal release. And remember, your nervous system always wins. Your nervous system always wins over your other systems. So stress, that is going to end up making you put out more cortisol. So I already said this, cortisol is huge in playing a homeostasis of your glucose, but it also helps increase blood levels of fatty acids, amino acids, and he is in charge of making sugar. So, you can store, let's say you have 12 Snickers bars, that's too much. So you're going to end up breaking down that sugar and storing it as glycogen for later. But what if you're not eating well? Or you're stressed. If you're stressed, you're going to end up putting out more cortisol, and that wants to increase the amount of sugar. What if you don't have a whole lot of stores? Your body can actually take fats and proteins and make glucose. Glucose, neo, birth, genesis, the beginning. So gluconeogenesis, the formation of glucose, thanks to fats and proteins. Our nervous system can only use sugar to make ATP. Our nervous system can only use sugar. Our nervous system cannot use amino acids and fatty acids. This is one reason why that keto diet is not necessarily safe. You do need some carbs. So the cortisol is going to encourage all the other cells to use fatty acids and amino acids for fuel. So what happens if you have too much glucocorticoids? Well, that would be causing a disease called Cushing's disease, and you're going to start breaking things down. You're going to start to have thinner skin, your cartilage, your bones not going to be as healthy. It actually can depress your immune system. So sometimes if you have an allergy attack, Benadryl's not working, they might give you a slam of steroids, because allergies is just an overactive immune response. You and I might be fine to a bee sting, but somebody else might get terrible hives. Give them a slam of steroids. Stop that reaction. It's an anti-inflammatory. So we have all kinds of inflammatory chemicals in our body, all kinds, and we'll get to that when we get to the immune system, and we'll mention it in blood too. But glucocorticoids actually are an anti-inflammatory property. So if somebody has arthritis and then they got into poison ivy. And they start taking a steroid pack to calm down the poison ivy, and all of a sudden they're like, wow, I feel great. My knees don't hurt. My hands don't hurt. It's because glucocorticoids cause anti-inflammatory properties. It's not the ideal drug to use on a routine basis, though. There's too many other side effects, so it's not a great choice for arthritis. So I said this already, hypersecretion of from the adrenal cortex releasing glucocorticoids causes Cushing's syndrome or Cushing's disease. It can be caused by a tumor on the pituitary gland. You can get a tumor on the adrenal cortex. And then Cushing's syndrome is actually when we start to take too much prednisone or dexamethasone by mouth. Maybe you're not taking it followed by the doctor. And this would be over an extended period of time. It's not like over a week or even a month. But treating it, get rid of the tumor or stop the medicines. This is an example of Cushing's patient. Also a picture from lab. It could be on your lab test. So here she is before the onset. Here she is later. She's starting to develop a little buffalo hump, which is fat on the upper back. It's kind of, it's not pathognomonic, but it's a hint that a person has Cushing's disease. You can see she's gained weight. She's retaining fluid. You can see that especially right in here. Now this one's a weird one. Addison's disease is when your adrenal gland is not putting out enough. And a lot of times when you have your adrenal gland not putting out enough glucocorticoids, it's also not putting out enough mineralocorticoids. It's a strange and rare syndrome, but because it is very non-specific. This person just is not right. And it's hard to diagnose. So I have a picture in just a second of someone that probably most of y'all know that he had this quite a while before it was ever diagnosed. It is treatable. You just need to catch it before the person dies. The initial signs, actually, it looks like this person's developing a suntan, even on the palms of their hands, despite not being in the sun. Here he is. JFK is a senator. He's very young. He's very dark. He started developing, he was very thin, just didn't feel good. And this is in the 50s. They couldn't figure out what was wrong with him. But when they finally did figure out what was wrong with him and treated him, then there's the JFK that we all know. Okay, the deepest part of the adrenal cortex releasing gonatocorticoids, mostly male-type hormones. It does release a little bit of estrogen or cause the conversion of those androgens to estrogen, but not a huge player in sex characteristics. It's minor. So what if you put out too much androgen, hypersecretion? Well, in children, what'll happen is the boys' reproductive organs will become mature sooner, develop pubic hair, maybe even have voice change. I mean, even 4 or 5 years old. In females, same kind of thing. They might get some pre-pubic hair. They might get developed breasts at 4 or 5 years old. Also, when we, at the end of AMP2, we're going to mention this again. During embryonic development, we have structures like early on, weeks after conception, that are homologous. So there's an area of tissue that for a male is going to become a penis, and for a female is going to become a clitoris. And depending on if you're XX or XY, it's going to determine how that develops, right? This is why you can't do an ultrasound really early, because really early, everything looks the same. So you can't tell if it's a boy or girl really early on. Well, if you are putting out too much androgen in a child, they're going to start to sexually mature early. Well, and that's called precocity, a precocious child. In an adult, as an adult, the adrenal gland starts putting out too much androgen. On a male, you'll never know. It's just they already have the beard, they already have the Adam's apple, they already have hair on their chest, whatever. It's really not going to be noticeable. On a female, they're going to start to develop facial hair. The bearded lady from the circus, she has a tumor probably on her adrenal gland, or it's malfunctioning and it's just putting out too much androgen. That's called virilism. Okay, the adrenal medulla. Remember, the medulla is nervous tissue, but it's putting epinephrine and norepinephrine into the blood. Collectively, epinephrine and norepinephrine are called catecholamines, and that'll be important in pharmacology if you start to go to nursing school. So what does catecholamines do? Well, fight or flight. You get vasoconstriction everywhere except your skeletal muscles because you're trying to run away from the bear. You're scared. Your heart rate's going up because we've got to pass blood to all your skeletal muscles because you got to get away from the bear. It increases your blood glucose level so that you have enough sugar to make enough ATP to go to your muscles to get away from the bear. You get the idea, okay? So if you get a tumor there, usually a pheochromocytoma, this is terrible. This can kill you. It's like you're constantly in fight or flight mode. It must be caught so that you can be treated so that you don't die. You can't stay in sympathetic mode. Hyposecretion is not, if for whatever reason your adrenal medulla is not putting out a lot, it really is not that big of a deal. Probably wouldn't even get caught. Okay, the pineal gland, so this is on the inferior and posterior part of the third ventricle in the wall. Kind of hanging from the wall anyway. He makes melatonin, and melatonin is released at the highest at nighttime. It makes us sleepy. We need that good sleep for not just growth hormone release, like I mentioned in the last PowerPoint, but also it affects sexual maturity and puberty. So, if you, let's say you have places like Alaska. Alaska stays light 24 hours a day during certain parts of the year. Well, those children are going to go through a later puberty because they're not releasing as much melatonin. To me, this is an interesting side note. The pineal gland has some calcium salts in it. So when you x-ray a skull, very often all you see is the skull. You can't see anything else. You can't see details of brain or anything. But sometimes if it has enough calcium salt in it, you'll see a little white dot in the x-ray, and you'd know that's the pineal gland. This is on the first one, just a summary of the different endocrine organs in the body, the major ones. We have other tissues that are going to release hormones as well, but not really listed in the endocrine system. Okay, the pancreas. The pancreas is both an exocrine and an endocrine organ. Next chapter, we're going to do its exocrine secretion, how it aids in digestion. Remember, exocrine has a duct. Endocrine, no duct. So the cells that are, when we look at, you are responsible for the histology of the pancreas. I'm going to show you that in a second. The majority of the cells are acinar cells, and they're releasing the enzymes that help digest our food. But then we have these little islands of cells that definitely, they're lighter in color. And they're called the islets of Langerhans. That's where the endocrine tissue is. And some of the cells are putting out glucagon, some of the cells are putting out insulin. The beta cells make insulin, and the alpha cells make glucagon. You don't have to recognize the difference between alpha and beta cells under the microscope. You just have to recognize the islets of Langerhans. So here we go. This is a histology of the pancreas. All of these cells right here, these darker purple, that's all acinar cells. These little circles, these islands of the lighter pink in color, those are the islets of Langerhans. That's where insulin and glucagon are made. Here's a different kind of stain. And on this one, you can actually tell the difference between the alpha and the beta, but so what? You don't need to know the difference between the alpha and the beta. You need to know which cells are endocrine and which cells are exocrine, and what do they make. So what does a glucagon do? You've been studying for A&P all day, and you haven't put a single drop of food in your mouth. Not a crumb. Okay? You have glucagon that's going to be released from your pancreas, and it's going to target the liver. Because the liver, remember those 12 Snickers bars that you had earlier? And I said, you don't need all that sugar, so your body's going to store it as glycogen. The glucagon is going to go to the liver, and it's going to cause the liver to start breaking down the glycogen. Glycogenolysis. Remember, lysis is to break down. Also, if you don't have a lot of glycogen stores, it's going to use the amino acids and some fats to create glucose. So the goal is to get more glucose in the blood. Insulin, its job is to get glucose out of the blood and into all of your cells. Because remember, inside your cell is where ATP is made. So when your blood sugar gets high because you just ate a meal, it's not doing you any good inside your blood. It needs to get into your cells so you can make ATP. So what it's going to do is it's going to aid in bringing that glucose into your cell. Homeostasis slide. Please review. Okay, so here's the biggie. There's diabetes mellitus. Remember, we did diabetes insipidus earlier, which for whatever reason you're putting out lots and lots of ADH. It got its name because it looks like diabetes mellitus. And they didn't know what the heck was going on, so they labeled it diabetes. It has nothing, diabetes insipidus has nothing to do with diabetes mellitus. Diabetes mellitus is the common diabetes that everybody has probably heard of. So there's two kinds. Type 1 is juvenile diabetes, and your your pancreas is not releasing enough insulin. Type 2 is the more common one that we hear about, that as we, diet and exercise and stop smoking and all that stuff, it can sometimes be reversible. It's because that insulin that you are releasing isn't being accepted for some reason. So what are the signs? PUPD, polyuria, polydipsia. You are urinating a lot and you are drinking a lot, because you have all this blood glucose, and so it's such a high level that your kidneys are like, okay, well, I usually save this stuff, but it's too high. I can't save this anymore. I've hit threshold. I'm going to pee this glucose out. Well, water is going to follow glucose. It's osmosis, right? You remember that from A&P1. So pee-peeing out glucose, so you're pee-peeing out water. So then your body's like, hey, I need some water. So you start drinking more. Polydipsia. Polyphagia. So you've eaten and all this sugar is floating around in your blood, but it's not getting into your cells. And so your brain's like, I need some food because my cells don't have any sugar. So I can't make any ATP, or not much. You're going to make some. Polyphagia is increase in food consumption. Over time, initially what'll happen is you can't use your sugar, so you start using fat. So initially what'll happen is you start getting a lot of fat in your blood, and you start using the fat for metabolism. So you lose weight, but you can't do that for an extended period of time. Here's another reason the keto diet is not safe. One of the byproducts of fatty acid metabolism is ketones. Ketones are acidic and poisonous. Ketones will kill you. Ketoacidosis is a crisis. It is an ICU situation, and prayers for getting out. Here you go. It causes you to breathe fast. It messes with your heart activity, oxygen transport. Your brain starts to get really, really sluggish. You go into a coma and you die. Can you tell I don't like the keto diet? So what would too much insulin do? If you have a tumor, an insulinoma, causing the too much insulin to be in your bloodstream, you're going to end up with low blood sugar, hypoglycemia. So an insulinoma can be kind of insidious and hard to find initially, maybe some fainting spells and stuff like that. But obviously, the more insulin it puts out, the lower your blood sugar. If it happens too long, you could die. What if you are taking insulin shots? You're busy. The kids are driving you crazy, and school is crazy, work's crazy, whatever's crazy. And then you're like, I usually take it at 6, but did I? I can't remember. Did I take that insulin? Should you skip it, or should you do it again? If you skip it, your blood sugar is going to get really high if you're diabetic. But is 12 hours of high glucose going to kill you? No. 1 hour of low blood sugar? Yes. Skip it. So this is showing how diabetes mellitus, so not having enough insulin, affects your body. Please review.
The sugary snack you devour enters your digestive system and is broken down to simple sugars like glucose. Glucose enters the bloodstream, causing an increase in blood glucose levels. But various mechanisms bring blood glucose back down to its normal level, the set point. This is an example of homeostasis, the body's tendency to maintain relatively constant internal conditions. Hormones produced by the pancreas regulate blood glucose levels. Let's zoom in. When blood glucose levels are high, glucose molecules leave the blood and enter beta cells in the pancreas. The beta cells respond by releasing the hormone insulin. Insulin enters the bloodstream and is transported to cells all over the body. Let's see what happens in the liver. Insulin binds to receptors on liver cells. This causes the cells to take in more glucose. Inside the liver cells, glucose is converted to glycogen, a storage molecule. blood glucose levels decrease as glucose is taken up by liver cells and other body cells. As a result, less and less insulin is released by the pancreas, and blood glucose levels stabilize at their set point. This is an example of how negative feedback maintains homeostasis. What happens if you've skipped lunch and your blood glucose levels are low? Let's zoom into the pancreas again. When blood glucose levels are low, alpha cells in the pancreas release the hormone glucagon. Glucagon enters the bloodstream and acts on target cells in the liver. Glucagon binds to receptors on the liver cells, signaling the liver cells to break glycogen down to glucose. Glucose is released, and blood glucose levels increase. As a result, less glucagon is released by the pancreas, and blood glucose levels stabilize at their set point. In this way, two hormones with opposing effects allow the body to maintain homeostasis of blood glucose levels. In diabetes, the body is unable to maintain homeostasis of blood glucose levels. In type 1 diabetes, the beta cells of the pancreas are destroyed by the immune system, and so no insulin is produced. In type 2 diabetes, the pancreas produces insulin, but target cells do not take up glucose. In both types of diabetes, when blood glucose levels rise, cells do not take up the additional glucose, and so blood glucose remains high. This example shows the importance of homeostasis in everyone's life.
Okay, so ovaries, testicles, placenta. These guys all produce steroid, so sex hormones. Estrogen and progesterone in the female. We'll get into a lot more detail of that in one of the last chapters of this semester. Testicles are going to produce testosterone. The placenta, we don't think about that very much, but it actually helps maintain the pregnancy. After the first trimester, it's going to release some estrogen and progesterone. Also, almost immediately after conception, it starts releasing HCG, human chorionic gonadotropin, because before the placenta is called the placenta, it's called the chorion. So, what is a pregnancy test checking for? HCG. Okay, so other organs that aren't really in the endocrine system, but they do also release hormones. I told you I'd mention them. So fat, we don't even think about that, but fat releases a few different kinds of hormones. They'll probably discover more details with this eventually that could help people lose weight. The GI tract. The GI tract has its own little brain, but we're going to learn in the next chapter about some neuroendocrine cells that secrete different hormones that trigger the release of different enzymes. Okay, so the heart releases ANP when the blood pressure is high. Kidneys, see how this one has a star? I think almost every test I could put a question on this hormone. Erythropoietin. Almost. I don't remember. But the kidneys put out erythropoietin that tell the bone marrow to make red blood cells. You know, your bone marrow makes red cells, white cells, and platelets. But a person in kidney failure is not producing enough erythropoietin, and so they're anemic. And talk about a hormone that shows up really routinely in internal medicine cases. So erythropoietin is very common, little asterisks, to show up on your lecture test. Renin, I've already mentioned that one. If your blood pressure starts dropping through the floor, your kidneys are going to recognize that. That's one of its jobs. And so it is going to release renin to initiate that renin-angiotensin aldosterone mechanism. In the end, remember, we're going to end up with some aldosterone, which makes you hold on to salt, which makes you hold on to water, which eventually raises your blood pressure. So AMP wants a lower blood pressure, and renin and aldosterone want a higher blood pressure. Skin. Cholecalciferol is considered a hormone. It's created by sunlight. It's the beginnings of vitamin D. The thymus, I mentioned this one earlier. This is also in the immune system or the lymphatic system. But the thymus releases thymosins. That's a type of hormone. So this is a list of the hypothalamic hormones. So please review that. And then this is all small. Was talking about how maybe our endocrine system doesn't develop properly because maybe some sort of environmental pollutant. And then as we get older, things just don't work like they used to. Here's a list of all that sadness. So chapter objectives. Can you identify how these organs, the endocrine organs, contribute to homeostasis? Do you understand the chemical composition of hormones and how they act? Do you know where the endocrine organs are and what their job is, what they regulate, what the effects of the hormones that they create are? Cool video.